Hi, everyone. I'm Raj Kumar, President and Editor-in-Chief of DevX, back again with my series of conversations during this pandemic with leaders across the global health and global development sector, and here with, I think, a familiar face for all of you following along around the world, Peter Sands, who's, of course, the Executive Director of the Global Fund to Fight TB and HIV and Malaria, and a leader in global health and somebody who I'm eager to kind of pick your brain, Peter, on the latest issues you're seeing on COVID, and especially as it relates to the disease areas you're focused on. And we're having this conversation here on a Friday, right at the tail end of the AIDS 2020 conference. So I think an opportunity to hear your takeaways from that as well. So thank you, Peter, for taking a little bit of time to join the discussion.
Well, it's great to be talking to you, Raj. And as you say, it's quite timely in the context of IS 2020. I gave my plenary speech to IRS just earlier today, in fact. And a lot of what I was talking about was the huge challenge that COVID-19 poses for HIV. It does as well for TB and malaria, but of course, in the context of IS 2020, I was talking about HIV. We face the really sobering prospect that if we don't mount an effective response, we could find ourselves losing maybe a decade's worth of gains in terms of the reduction of death, the reduction of infections. So there's a huge amount at stake.
Yeah, and I think even before the COVID-19 came on the scene, there were questions about the direction of the response to the HIV epidemic and how well it's going. I know among adolescent girls in sub-Saharan Africa, numbers were increasing. There were challenges on the funding front, and especially in terms of domestic resource mobilization. So it wasn't exactly as though everything was, going swimmingly. And then this pandemic hit. We actually had some real challenges in the background. And now with the pandemic, you have people who maybe can't get out to see their healthcare providers, can't get as easy access to medication that they need. Maybe funding issues are cropping up. I mean, maybe you can take us through, what do you see as some of the ways the pandemic is directly affecting the fight against HIV?
Well, as you say, if you take a step back, it feels like ancient history now, right? The Global Fund Replenishment back in October in Lyon. The whole kind of message there was that we're not on track. We've done a pretty good job on reducing the number of deaths, but the rate of reduction of infections is not fast enough to get us to where we want to do. We said to donors that we had to step up the fight, and to their credit, donors did step up, and we successfully raised 14 billion, and that enabled us to increase our allocations to countries by over 23%, which is a pretty significant number when this is $14 billion. And so we actually entered 2020 thinking, now's the moment. We have to seize this moment, get back on track, really make some significant sort of steps forward, accelerate the path towards ending the epidemic. And then, of course, COVID comes. And COVID has changed the world of global health. And there's no sort of getting away from that. And will continue to be a massive force changing the way we think about these things for several years to come. In terms of the practical near-term implications, a lot of what you've seen actually is the impact of the lockdowns on both treatment and prevention services for HIV. What I think we're now transitioning to is actually the impact of the pandemic itself, of the virus. For the lockdowns, what you saw was lots of issues around the supply chain, around people on antiretroviral treatment, finding it difficult to get access to their medicines, and also prevention activities, many of which are face-to-face in nature, particularly the ones which are about behavioral change, education, and so on, heavily disrupted. We also saw a disturbing rise in human rights-related barriers to accessing health services, people using lockdown to sort of accentuate discrimination and stigma. Now, there's been lots of imaginative responses. We've been We've had NGOs running kind of courier services to deliver antiretrovirals to people living with HIV so that they don't have to expose themselves. There's been lots of fairly obvious things like multi-month dispensing so as to reduce the frequency of visits. We've also, with the most vulnerable, we've been supporting nutritional support and so on. So there's been a lot of responses, but I don't think we should kid ourselves. This has not been good for either treatment services or prevention services. And as we go into this next phase, which is less about the lockdown and more about the virus itself, what I'm most worried about is the health workers. And I don't just mean salary doctors and nurses, I mean the people within the communities who are providing services, providing outreach, because there aren't that many of them, and there's very little backup to them. And if they fall sick or have to isolate, then the services will begin to fall apart pretty quickly. So we're putting a lot of focus on the importance of protecting health workers, of providing them with PPE, training them, because they are you can have as many medicines and instruments and tools as you like, but if you don't have health workers, the system isn't going to function.
Yeah, and that was a big theme in the early going, and a big part of what happened in places like Italy and China was protect the healthcare workers, and PPE became a phrase everyone in the world is familiar with, that acronym now. What is your take, and you look across the many countries Global Fund works with? Has that been effectively addressed? I mean, are healthcare workers have access to PPE?
Not at all. When you think that the situation in many advanced economies on PPE is still pretty chaotic, the reality is that there isn't nearly enough access to PPE. And it's not just about buying the stuff. What you need is a proper process and system that says who gets what on, at what time, in which way, and also how do you dispose of it? Because reusing PPE or using it too much that's not a good idea. And so there are significant issues around both securing access, buying the stuff, getting it delivered, but also then getting it managed within a healthcare system, and ensuring, as I say, that it doesn't just go to the sort of the people working in hospitals, but it goes to the people who are really on the front line, working with the sex workers, working in the harm reduction programs, working to find and identify people with TB who haven't been identified, or people doing indoor residual spraying for malaria. You need all these people to be protected as much as you can. And the other point, of course, is if you don't protect them, particularly, say, a community health worker, they can inadvertently become a vector of transmission for people who are immunocompromised or vulnerable. And so you really don't want that.
And they're, of course, going door to door. They're seeing lots of patients. Yeah, their chances of getting the virus are much higher, and then they could transmit it to many more people. Absolutely.
So we acted pretty quickly, in the sense of right at the beginning of March, we introduced a whole set of flexibilities in the way countries could use savings within their grants or do a limited amount of reprogramming to respond to COVID. And that made about $500 million available to countries. But we knew that wasn't going to be enough. So we introduced, in April, we introduced another mechanism called COVID-19 response mechanism, not very imaginative, C19RM. And that made another 500 million. So $1 billion in total. And we're working with countries to use these funds to both adapt the HIV, TB, and malaria programs, to protect health workers, to do some urgent fixes on health systems, particularly on things like laboratory networks, which are getting very overstretched. And also then to help them with the provision of some of the basic tools for fighting COVID. above all, in the short term, tests, being able to diagnose COVID cases.
Have you had any pushback from donor governments who say, hey, you're expanding your remit past what you're funded to do if you're now getting into things like healthcare worker protection? Or has the donor community been very understanding and sees all the linkages here? How much of your time is required to kind of bring people along with the strategy?
Well, we've had a lot of questions, and not just from the donor community. We've also had it from people within the different disease communities, because they're nervous. They're saying, sort of, are you diverting money away from HIV or TB or malaria? And my response has been to deliver on our mandate, which is to end the epidemics of HIV, TB, and malaria. We have to help countries respond to COVID, because if the system is overwhelmed, if the health workers get sick, if the resources are diverted, which they are being from HIV, TB, and malaria, there's no way we're going to deliver on our mandate. So we have to lean into the COVID-19 crisis. And I think actually the people on the ground actually absolutely buy it, because they can see the reality of what is going on. And I think increasingly, all our stakeholders kind of see the logic of that.
Do you think, you were just talking about how the replenishment happened, it seems like another era ago, but just back in October. Is there a chance that, given you have to put out $1 billion in this area, that the COVID pandemic is not over by any stretch, that you'll need to go back for more funding sooner than you might have otherwise planned in order just to hit the objectives you already put out there back in October?
Well, we are telling donors that, we can't divert the 14 billion, which doesn't start the 14 billion until January of 21. We're saying we can't divert that to COVID, because we will start 2021 further back than we intended to be, right? That is the harsh reality. COVID will have knocked us back a bit. And so if we have any ambition to continue the fight on HIV, TB, and malaria and get to where we want to, we've got to commit that 14 billion to HIV, TB, and malaria. And the other point is domestic resources have definitely been diverted to COVID-19. And so some of the increment we're going to have through that 14 billion is effectively going to be filling the gap from domestic resources. So the first point we're making is, don't think we're going to divert that money. That money is for HIV, TB, and malaria. However, we have a whole bunch of countries that need to do a lot of stuff now. And we have essentially emptied the pockets of the global fund with our $1 billion now to help countries. And that was, in a sense, all the money we could potentially have left over from the fifth replenishment before we start the next grant cycle. And we have gone out to countries and said, this is not going to be enough. Countries are going to, we've gone out to donors, sorry. Countries are going to need more support. We actually produced a paper, a report about 10 days ago, where we said, which was entitled, Mitigating the Impact of COVID-19 on Countries Affected by HIV, TB, and Malaria. Not the world's most imaginative title, but it tells you what we were talking about. And in that, we said countries need $28.5 billion. Now, we're not saying that that all needs to come to the Global Fund, and we're saying some of that is there already, but it's less than half of it is there already. And we also said, if you want the Global Fund to play the role in mitigating the impact of COVID-19 that it plays in the fight against HIV, TB, and malaria, you're basically talking about another $6 billion the Global Fund needs to deploy. If you take out the 1 billion we've deployed already, that's about 5 billion. And we have already some contributions. Indeed, it was only a week ago that we got 150 million euro from Germany. We've also had $1.5 million from FIFA, which has been matched to make it 3. So we're beginning to see donors respond to this. And they need to. The reality is that COVID is not going to be solved within existing development assistance envelopes. It's going to require a somewhat different way of looking at it.
Yeah, and there's advantages to, given the urgency, to working through an existing institution like yours. Even though you have disease-specific mandates, you still work at a systems level, and there's an opportunity to work through something like the Global Fund rather than trying to stand up a new fund. There has been a bit of a conversation about that. I've heard conversations around a global fund for COVID or around a global fund for health systems. I wonder what your take is in terms of the architecture. I remember when we spoke last, you said it was your nightmare to imagine adding COVID to the list of your disease areas because it would mean that we hadn't actually addressed it. And it became one of these epidemics that maybe gets addressed in rich countries, but persists in poor ones. What do you think happens to the architecture going forward?
I don't know. There's a lot of debates about this, but I think certainly in terms of the firefighting, it makes no sense at all to create new organizations. We should bend and stretch and modify the existing organizations. But the reality is in institutions like Gavi, the Global Fund, the World Bank, and so on, you have organizations which know how to deploy money, know how to control it, assure it, risk manage, procure, integrate with, and we got the partners and relationships, we can do the monitoring and evaluation. You just do not want to try and create all that kind of thing again. And when you think about the Global Fund was created to fight the last big pandemic to hit humanity, HIV and AIDS, right? That's what we were created to do. The Global Fund is an institution designed to fight big infectious diseases. This is a different infectious disease, and it has some different parameters around it. But there are a huge number of things that we do already that are critical to the fight against COVID. And indeed, if you look at actually what is going on the ground, is a lot of it is the infrastructure and capacities that we and others have helped put in place that is now being used for COVID. So if you take diagnostics, for example, the most sophisticated, faster throughput diagnostic tools that most developing countries are using are the automated PCR tests that are being run either on machines that have been put in there for HIV viral load testing or on machines that have been put there for TB diagnosis. So it's not like it's a completely different set of people and infrastructure and capabilities that you need. It's the same sorts of things. The other reason I think it's really important to think about this in a integrated way, and why we think it's critical to, as I say, lean into the response, is in many of the countries in which we invest the most, the knock-on impact of COVID, i.e. the indirect impact on the number of deaths due to HIV, due to TB, due to malaria, but also more broadly, maternal health, immunization, and so on, could be as bad, if not worse, than the direct deaths due to COVID. Now, we don't really know, but if you think about the demographics of, say, some African countries, they actually don't have that many old people. Africa, sub-Saharan Africa, I think 3% of the population is over 65 compared to nearly 20% in Europe. And we know that COVID mortality is very skewed towards older people. So you might have, for any given number of infections, less mortality. But on the other hand, you might have a much more powerful knock-on impact in terms of incremental mortality for HIV, for TB and malaria, and so on. And I think
that's because people aren't getting access to the treatment or the prevention, and even things like livelihoods, the nutrition that they need to go along with treatment.
Yeah, you get into a really difficult spiral of people avoiding going into clinics because they're scared of COVID, the community health worker being sick themselves, the underlying health of people due to nutritional deficiencies and things deteriorating. And you can see that this could be a pretty nasty scenario. And what I think it means is that the measure of success for the COVID-19 response cannot just be, like it is in most advanced economies cannot just be measured in terms of the numbers of people, minimizing the numbers of people dying who test positive for COVID, because we'll be missing the entire knock-on impact. We need to be looking at the total excess deaths and how we minimize that. And that requires really thinking quite carefully about, in a sense, relative priorities. I mean, for example, what we're seeing is quite a diversion of laboratory resources away from viral load testing and away from TB diagnosis. TB case notifications in many countries have fallen by 30 to 60%. I mean, that will end up causing more people dying of TB. And so we need to ensure that we really think about how to problem solve to keep going with TB case identification and notification and treatment, as well as doing the COVID-19. It's no success to have somebody say from dying of COVID-19 and then have them die of TB. But likewise, we don't want to say them TB and then have them die from COVID-19 either.
Yeah, it's hard to say given the number of deaths so far. And obviously, it's something could happen in a second wave, maybe that's more deadly in the fall. But it seems like probably more people will die in 2020 from TB than from COVID at this stage. At least that's the sense I get from the numbers, right? If you're at about 1.7 million TB deaths annually. The other question that raises for me that we talked about last time we spoke, and I wonder if you have an update on the science behind this, whether people who are suffering from malaria, TB, or HIV are at greater risk for death from COVID-19 if they contract it. Do we yet know any more about the interaction of these diseases?
There's certainly some evidence coming out of South Africa. There's been some work in South Africa that suggests that people with TB have a higher probability of a severe case and a higher probability of mortality for COVID. I've seen less clear evidence thus far on HIV, but it's quite complicated because, of course, in a place like South Africa, a lot of the TB is correlated with HIV anyway. So you're actually looking in many of these cases at somebody who's got HIV, TB, and then catches COVID. And yeah, the evidence suggests that, you know, that's not a good place to be. And that shouldn't really surprise, because if you're immunocompromised or you've already got lung dysfunction, you're not starting from the best place with a disease like COVID. But look, I hesitate to sort of draw. I think we're still learning an awful lot about this new virus, but I think we you know, if people are being treated for TB or people are on antiretroviral treatment, we should be minimizing the probability of them catching COVID, right? That is unambiguous.
How do you think about this from a time frame perspective? In other words, you talk about the firefighting. Are we going to be in this sort of firefighting mode through 2020 and maybe 2021, especially in the countries where the Global Fund primarily operates? I mean, do you think that this is the kind of thing that could stretch out even further than that and really change this sort of the new normal of how Global Fund operates? How do you think about the timeline inside the Global Fund right now?
Well, we think about the timeline basically by saying, well, it depends on a couple of critical things. One is, do we and when do we identify a vaccine? And secondly, when do we start seeing a more powerful array of therapeutics that cut mortality? And we're beginning to see, we're seeing progress on both fronts, but, we've got remdesivir and dexamethasone on the treatment front, and there's lots of interesting, there's 200 or something vaccine projects out there. But none of the treatments thus far are a silver bullet. And we have no idea whether really we're going to, what kind of vaccine we're going to get and when. So our working assumption is that we are going to be in a pretty tough situation for the rest of this year and most likely the whole of 2021 as well. Because even if we discover a vaccine, the sort of sheer scale of the manufacturing challenges, the deployment challenges, and all that sort of stuff means there's going to be a lot of people who aren't going to be protected by a vaccine still in the second half of 2021. And so we need to be, and the economic impact of all of this and the broader pressures on the health system, they're going to kind of reverberate through 21 and may well be, it's not like I'm saying they'll be done by then either. It really depends on how quickly we develop these tools, but also how much resource we put into mitigating the impact. I mean, there's a sort of, there's a disconnect actually going on here, which is that when you look at the way the advanced economies have responded to the crisis, they have broken all their own fiscal and monetary rules, right? They have literally thrown money at the problem. And I've seen estimates around $9–10 trillion that the OECD countries have used to respond to their domestic crises. But actually, when you look at what's going on in the low and middle income countries, ODA budgets are essentially flat. And there's been a lot of reprioritization, but the basic envelope for ODA isn't really changing materially. And so there's a sort of logical disconnect there, because essentially the rich countries of the world have said, we have to do extraordinary things and break all our own rules and throw money at the problem to solve our own problem. But in effect, they're asking the developing world to solve the problem within an existing budget envelope. Because developing countries, in terms of their domestic resources, they can't expand their central bank balance sheets and things. Their currencies would collapse. Just, they can't suddenly borrow more. That doesn't work. So really, the only thing that could help them do anything like the kind of extraordinary response that the rich countries have done would be a step up in ODA. And at the moment, we're not seeing the appetite to do that. But I actually do think that that is what needs to happen.
Well, either a step up in ODA, or the other thing people are calling for is a cut, to debt, maybe even canceling debt as another possible measure to get governments that have budget limitations now to be able to spend more on health. And DevEx has been reporting on this in some countries. I think Nigeria is talking about a 40% cut to their healthcare budget. I mean, you have many countries there, one, where the oil prices that have dropped precipitously, in part due to the economic consequences of COVID, also means they're going to have significant budget challenges. So I wonder how you think about that debt option versus an increase in ODA, and how you would weigh those.
Well, I actually think you need to do a bit of both. I certainly think that some of the debt cancellation is part of the answer. I'm not sure, though, that it is all the answer, because in a sense, because of the way debt repayments work, is in a sense, you only get a fraction of that in the first year, right? You get the interest payment and a bit of the principal that you might have paid on an amortizing schedule. You don't. So the difference, in the long run, it's a great thing. The trouble is, this is not a long run problem. I think that is part of the equation, but we also need cash on the table right now, new cash on the table right now, and in substantial scale. And if we don't, and I think it's a false economy not to do it, because there is a sort of cascading set of nonlinear, you can tell I was an economist by background, cascading set of nonlinearities, which means that basically if things start falling apart, they'll make the other bits fall apart, and the consequences will get worse and worse. and they'll get worse in a way that is a non-linear thing. And you could see that in the pressures on health. You saw it in the way when health systems get overwhelmed, mortality goes up very, very sharply. When you've got fragile health systems, fragile supply chains for food and so on, fragile political systems with underlying tensions and violence, you put all that together, you overstretch it, you don't respond big enough and fast enough, you can end up in a place which is very, very nasty and will cost far more in terms of lives and in money to sort of return to any kind of peace and progress. And so I worry we're being a little short-sighted or a little kind of capped in our thing. And this is also, I suppose, I'm bringing a little bit of the experience of having been pretty deeply involved in the response to the global financial crisis.
Sure. You were CEO of Standard Chartered Bank, one of the biggest banks in the world.
Yeah, and I was quite involved with quite a lot of the policymakers and central bank governors as to how we actually devised a response that would work. And the big thing that happened in the early part of sort of late 2008, early 2009, was the realization that you had to go big. And it was actually much better to err on the side of going too big than it was to err on the side of not going quite big enough. And there was actually relatively little, in a sense, cost to going too big and massive cost to going too small. And that this had to be done at a global level. And I don't think the thinking on that has quite got there yet. But I think we need that kind of mindset, which is, and it's not just about the development side of it. I also think it's in the amount of money we're putting into the tools side of it, the diagnostics, the therapeutics, and vaccines. I think we'd be far better sort of overdoing it there, because frankly, if we go down some blind alleys, those are blind alleys that will yield benefits for other diseases and other healthcare priorities, right? There aren't really blind alleys in clinical research. You always find useful stuff. It may just not be what you were looking for. But the prize, when you see the calculations of what it costs to have the world economy kind of hampered by lockdowns every week or every day, it's not rational to not be investing more.
And yet, I agree with you completely. And yet, there isn't much happening in that area, and the narrative isn't quite there. As you say, there's almost an unlimited checkbook for fiscal and monetary stimulus in the advanced economies, and then not much conversation about new envelopes, about new funding. I mean, you say you're looking under the couch cushions for that last billion right now as an institution, but the donor countries are giving small amounts at this point. It feels like that realization might be pretty clear to you and me, but it hasn't quite hit the donor capitals at this stage.
Yeah, no, I think you're right. And it's, I think part of the issue is that what you've seen is the finance ministers and central bankers who've developed some very powerful tools in the wake of the global financial crisis, using those tools and using them pretty effectively. And the issue, though, I think, is that the tools are being deployed to deal with the economic and social consequences in their own countries of the crisis. They're not really dealing with the root of the crisis, which is a health crisis, and they're not really dealing with the consequent impact on the poorer parts of the world. And certainly my view is we need to get that same, a fraction of that firepower. And I mean, if you take 10 trillion and you say, I want 1% of that, well, 1% is 100 billion. I would settle for 100 billion. But 100 billion split half for accelerated the R&D and half for mitigating the impact on low and middle income countries. That's the kind of thing we ought to be talking about. And that is the kind of, otherwise, if we don't do something of this kind of scale, on the one hand, the world economy is going to lurch around with partial lockdowns and, you know, things surging and then flattening, and that kind of uncertainty for business and is going to be hugely disruptive and costly. I mean, the cost of that is just mind-boggling. But also, if you're taking a development perspective, I mean, we risk losing the whole SDG agenda, right? The whole thing being derailed. And the cost of, in human terms, and the cost in monetary terms of sort of getting back on track I mean, we were looking at this in the context of HIV. If you look at the kind of UNAIDS scenarios around what could happen as a result of disruptions to treatment, you could be looking at going back to the death rates we last saw in 2008. Now, that's shocking from a human cost, but also you think, how many tens of billions of dollars have we spent getting from where we were in 2008 and to now, right? It must be 40, 50 billion dollars at least that we spent. So just in economic terms, to allow that to happen when, you know, on that particular problem, I would say a few billion, you know, low single digit billions could prevent that happening. Just in pure economic terms, it seems like a compelling case to deploy money now.
Yeah, it seems like that's the case to me too, although it will mean maybe a different way of thinking at places like the Global Fund and PEPFAR, because for so many years now, these institutions have been saying, we want to partner more with the countries we work with. We want them to spend more of their domestic resources. And you know, PEPFAR has been trying to focus using data where it spends its money and then asking governments to pick up the rest. And yet it's possible we'll be looking at a few years or more where these countries just don't have the domestic resources to play that kind of role. And so we'll have to look at more ODA, and it really might change. I don't know what you think. It might change the way the institutions like yours even have to work.
Well, it definitely makes the conversations about co-financing, sort of the transition conversations and things, these are all going to have to be looked at with a different lens, right? Because the economic situation of some of these countries is going to be extremely challenging. I mean, I think there were some good things. I don't want to paint, you know, too dark a scenario. What you are seeing actually is a lot of innovation. We're seeing the pickup of innovation. So things like self-testing for HIV, this has been a catalyst to people wanting to move faster on that. I think we're seeing people working in partnership because faced with a challenge like this, people really do sort of put shoulders together and make things happen. I think another thing, certainly one of the things we've done is move at speed. And one of the things that struck me coming into the global health world was that things sometimes took a long time, let's say. When you're responding to a crisis like this one, either to the virus itself or to the knock-on impacts, you got to move with speed. And I think some of that dynamism and intensity of collaboration and willingness to embrace innovation, I hope that we can keep those things when we get to, you know, I hesitate to say the word normality because I'm not quite sure what that consists of now.
Yeah, I hear that from other leaders too, this idea of urgency, this new pace of working, this kind of cutting through the cultural barriers between private companies and NGOs and UN agencies and others, that this crisis has maybe given us a chance to see past that, and that maybe that will sustain. And I know, you know, Dr. Birx, Debbie Birx, when I interviewed her just before she took on her new role, you know, leading the coronavirus response in the US, she always cautioned us to not just look at the total dollar amounts, but look at what the dollars buy. And her argument was, the dollars now buy a lot more than they did when it comes to things like HIV treatment than they did 10 years ago. And that this idea of innovation, that there's huge opportunities even within the funding envelopes that we have. Of course, again, this is pre-coronavirus, but that even within the limited funding structures, there's much more we could do with it if we take an innovation lens to it. And maybe a crisis like this is going to force that.
Yeah, and I think it is forcing us to think differently about a whole bunch of the way we do things. But I also think we want to make sure we learn the lessons from what we've done in the past. So, for example, I'd say that many of the initial COVID responses were really quite kind of technocratic and top down. And if there's one thing we've learned in particularly the fight against HIV, is that if you don't have community engagement and leadership, you won't get there.
Are you thinking about things like mask wearing and social distancing? Give me an idea what you mean that didn't get the community buy-in.
Well, I think mask wearing is a very good example. You see very different levels of buy-in in different parts of the world. But also the reality is things like contact tracing. Contact tracing requires the community to believe it's a good idea and to trust the way it's being done. Or social distancing in places where there's very dense population. If you've got social distancing in a slum, then that has to be organized. And those people have to be supported with food. And it's communities that are going to do that kind of thing. And in some ways, the countries that have been heavily affected by diseases like HIV have a bit of an advantage because they already know that and they already have those kind of structures and ways of thinking about how to fight disease in a way that perhaps in some of the more richer countries, we've kind of forgotten that there's only so much a health system can do. There's a big part of fighting infectious disease, which is about how individuals and about how the community responds. And I think you've seen different countries and different communities have struggled with that as to how to make that happen.
I know we're running short on time, but maybe one last theme for me, and unless there's anything else you want to get into, I'm just curious about how you think, especially given the timeline you suggested, which is pretty long, how you think this is going to affect the work of your colleagues at the Global Fund, at the other institutions you partner with, the NGOs and others. Devex, we've been running a tracking poll and finding some pretty negative consequences for NGOs who say their funding is going down. People, job security is going down. And even the way people work, right? And we're an industry that you and I see each other constantly in cities other than our own home, constantly traveling. The global health industry is kind of set up that way. And yet you've just come from your virtual plenary, the Big AIDS Conference 2020, and you and I are talking now this way. What do you think in terms of consequences for our work life in the global health field? How do you see that developing?
Well, one of the things, a couple of observations. One is that actually, some of this stuff, some of the online interaction is a real step forward, right? I already was a bit kind of grumpy about how much time and money we were spending flying to different parts of the world from Geneva to hear somebody from Geneva stand on the stage and talk about something and discuss it with other people, from Geneva or Washington. And, that didn't make any sense at all. There was, frankly, in the global health world, too many of those sorts of conferences. And I think what we've discovered is that you can run those kind of conferences as well, and in some ways better, by doing them online. And so I don't think we should pull back from that. And, the Global Fund has been running board committees and the board and all sorts of stuff online. And I think we need to think very carefully before assuming we're going to rush back. And apart from anything else, from a climate point of view, it's a huge step forward. That said, there are some things we do need to travel for. If you really want to understand what's going on in a complicated and difficult HIV prevention program, or a awkward political situation where things on paper don't seem to quite correlate with what you're hearing, you need to go to places and you need to talk to people on the ground. And I would also say that building relationships is harder online. When you have a relationship with somebody, when you know, so I know you, it's easy enough to do. But when you're meeting people cold, it's a harder thing to do. So I think we will revert to traveling, but I think we'll be very thoughtful about the way we travel, and what we travel for. And I hope we will cut out some of the kind of conference merry-go-round. I also think people's work life between home and work is going to change. I don't think it'll be binary in the sense of we won't have offices anymore. But I suspect that people will want to go into work some of the week and be home some of the week, and that individuals' patterns of doing that will vary. And that means we're going to have to think very hard about the way teams interact, because you don't want situations where where some people are sort of together in the office and some people feel isolated because they're not, and that kind of thing. I do think we need to also be very prioritized and focused. When you have really big stuff happening, when millions of lives are at stake, then certainly my patience for some of the more interminable discussions in the world of global health gets pretty short. We simply don't have the luxury to debate things that aren't that important. We need to be incredibly focused. I'm also concerned that there's a different dynamic. When the crisis first erupted, a lot of people were kind of on adrenaline and working frantically hard, responding to the immediate crisis, and huge dedication, huge commitment and professionalism. But we also need to ensure that the people pace themselves, because if we're looking, as I think we are, at fighting this thing over, undoubtedly through the middle of next year, probably into 2022, at some level of intensity, then people have to find a way of, this is a marathon, not a sprint type situation. So it's, we're going to be finding out a lot about ourselves as individuals, about the way we work in organizations, about the way we partner with people. And I do think there'll be some real positives out of that.
Well, thank you, Peter. It's always a real pleasure and fascinating to get your take on all these issues. Thank you for being willing to have this conversation across so many themes. And these are issues we're obviously covering and dedicated to covering at DevX. The interaction of COVID with other disease areas, what it means for patients and people, what it means for the institutions like your own that are working on this is a top priority for us. So thank you for taking time to do this. And let's do it again soon, if you don't mind. I'd love to continue to get your take on this going forward.
As always, it's a great pleasure to talk with you, Raj.
Thank you.
Excellent.